Good day, everyone. This is our case presentation about heart failure, and we are here to discuss about the pathophysiology of the disease, signs and symptoms of the disease, possible consequences or complication of the disease, treatment guidelines for the disease. Next.
So we will start to the pathophysiology of the heart failure. Next. These are the difference of the kinds of a heart failure. The first feature is the heart failure with reduced ejection fraction. It happens when the muscle of the left ventricle is not pumping as well as the normal. The ejection fraction is 40% or less. And the next feature is the no heart failure. And the third feature is the heart failure with preserved ejection fraction. It is a clinical syndrome in which patients have clinical features of heart failure in the presence of normal or near normal left ventricle ejection fraction, usually defined as ejection fraction at 50% or above. Next. This is the heart failure pathophysiology. The congestive heart failure results in the activation of multiple compensatory mechanisms in an attempt to increase cardiac output. This frequently work in the short term. However, the long-term effect can be detrimental to the heart via negative remodeling. The, true, the two primary mechanisms consider the neurohormonal response are activation of the sympathetic nervous system and activation of the renin-angiotensin-aldosterone system. Medical therapy is aimed at reducing the activity of these two systems. A third compensatory response occurs via B-type natriuretic peptide and A-type natriuretic peptide. Next.
So here are the signs and symptoms of patient having a heart failure. So here are the signs: chest pain, shortness of breath, dizziness or lightheadedness, swelling of legs, hands and feet, sudden weight gain, sudden fatigue or weakness. And here are some symptoms of heart failure: extreme tiredness or no energy, rapid heartbeat or palpitation, and then loss of appetite, and then more on coughing or sneezing, and lastly is frequent urination, especially at night. Next.
And also we will tackle the complication of the heart failure. We have the kidney damage, heart valve problem, heart rhythm problem, liver damage, pulmonary complication, stroke, organ failure, and sudden death. Next.
So here are the clinical practice guidelines. So why clinical practice guidelines such as in American College of Cardiology? So it is important because it aims to define the most effective combination of symptoms, signs, and investigation required to establish a diagnosis of heart failure and those which will influence therapy or provide important prognostic information. It is also gives guidance on the treatment, monitoring, and support of patient with heart failure. Next.
And this is the actual patient case of a heart failure. WC is a 67-year-old man with hypertension, hyperlipidemia, and coronary artery disease, and had triple bypass surgery 17 years ago. His current home medication include amlodipine 10 mg once daily, atorvastatin 80 mg once daily, and aspirin 81 mg once daily. He presents to the clinic with shortness of breath, which occurs when performing simple tasks such as sweeping the floor, He reports that sleeping in a recliner at night due to orthopnea, and the physical examination reveals elevated jugular venous pressure and more than one pitting lower extremity edema. An echocardiogram demonstrates systolic dysfunction, mild mitral regurgitation, a dilated left atrium, and an ejection fraction of 30%. Laboratory results show a pro-B-type natriuretic peptide level of 1,302 pg per ml, a troponin level of less than 0.34, and unremarkable basic metabolic panel. Measurement of vital signs showed blood pressure of 156 over 92 mmHg, a heart rate of 80 beats per minute, and oxygen saturation of 94% and temperature of 36.5 degrees Celsius. A pain level of 2 on a scale of 10 and a weight of 185 pounds or 84.1 kilogram. WC's pharmacy coverage is Medicare Part D. The medical team would like assistance in optimizing the medication regimen for WC's new diagnosis.
So here are the subjective information of the patient. He reports sleeping in a recliner at night due to orthopnea, and also he presented to the clinic with shortness of breath, which occurs when performing simple tasks such as sweeping the floor.
So this also the objective information or the patient information. WC is a 67-year-old man with hypertension, hyperlipidemia, and coronary artery disease, and had triple bypass surgery 17 years ago, and is sleeping in a recliner at night, shortness of breath, blood pressure of 156 over 92 mmHg, and a heart rate of 80 beats per minute, and oxidation saturation of 94%, a temperature of 36.5 degrees Celsius, a pain level of 2 on a scale of 10, and a weight of 185 pounds or 84.1 kilogram.
So the patient lab test shows that his physical examination reveals elevated jugular venous pressure and more than one pitting lower extremity edema. He is also systolic dysfunction, mild mitral regurgitation, a dilated left atrium, and an ejection fraction of 30%. And he also have a pro-B-type natriuretic peptide of 1,302 pg per ml, a troponin level of less than 0.34, and unremarkable basic metabolic panel. Next.
And his medication include amlodipine 10 mg once daily, atorvastatin 80 mg once daily, and aspirin 81 mg once daily.
So, assessment based on the information gathered on the patient. So, here are the problem list. Triple bypass surgery 17 years ago, and an elevated jugular venous pressure and more than one pitting lower extremity edema.
So we have the objective information show the lab tests of the patient. First one is the physical examination reveals elevated jugular venous pressure and more than one pitting lower extremity edema. Based on the National Library of Medicine, that elevated jugular venous pressure is a manifestation of abnormal right heart dynamics, most commonly reflecting elevated pulmonary capillary wedge pressure from left heart failure. This usually implies fluid overload, indicating the needs for diuresis. The second one is the systolic dysfunction, mild mitral regurgitation, dilated left atrium, and an ejection fraction of 30%. So based on the National Library, that 30% to 40% moderately abnormal. And the third one is the pro-B-type natriuretic peptide level of 1,302 pg per ml, a troponin level of less than 0.34, and an unremarkable basic metabolic panel. So for the NT-proBNP, normal levels are less than 125 pg per ml for people under 75 years old and less than 450 pg per ml for people over age 75. So based on the patient, that 67-year-old man that have a 1,302 pg per ml has a signs of a heart failure. Next.
So based on the medication of the patient, he is taking amlodipine 10 milligrams once daily. So as we compare in a clinical guidelines article, that it shows that prescribing amlodipine in adults with 10 milligrams once a day, as the doctor prescribed, is that it can manage the chest pain, and also 10 milligram of amlodipine per day is the maximum dose for a patient. So second medication is the atorvastatin that have 80 milligram once daily. So as we compare also in a clinical guidelines article, that 10 to 80 milligram by mouth once a day can reduce the risk of stroke and heart attack in type 2 diabetes patient without evidence of heart disease but with other cardiovascular risk factor. It is also reduce the risk of stroke, heart attack, and revascularization procedure in patient without evidence of coronary heart disease but with multiple risk factors other than diabetes. And lastly, patient with CHD to reduce the risk of myocardial infarction, stroke, revascularization procedure, and hospitalization of CHF and angina. So last medication of this patient is the prescribing aspirin with 81 milligram once daily. So as the other practitioner, low doses of aspirin such as 75 to 100 milligrams are common, but 81 milligram of aspirin can be effective at preventing heart attack or stroke, which is the patient's condition. So all his medications are good to manage his condition.
So we have also the subjective information. I said a while ago that he reports sleeping in a recliner at night due to orthopnea. So orthopnea is the sensation of a breathlessness in the recumbent position, relieved by sitting or standing. And also, he present to the clinic with shortness of breath, which occurs when performing simple tasks such as sweeping the floor. So dyspnea refers to the sensation of difficult or uncomfortable breathing. It is a subjective experience perceived and reported by an affected patient.
So in our assessment, the drug therapy problem of this patient is he needs additional drug therapy because there is no management in his current medication, which is heart failure and dyspnea. So before the recommended medication, let's first discuss why the medication we mentioned a while ago are prescribed in this patient. So why amlodipine is prescribed? Amlodipine is used with or without other medication to treat high blood pressure. It is also good in lowering high blood pressure, helps prevent stroke, heart attacks, and kidney problems. And also, amlodipine is part of the calcium channel blocker. And also, amlodipine is used to prevent certain types of chest pain. So, thus, calcium channel blocker are good for patients with congestive heart failure. It's partly yes and no. Why? It's because non-dihydropyridine are contraindicated in patient with heart failure with reduced ejection fraction. So this patient are not or he must avoid verapamil and diltiazem because it's not good in congestive heart failure. While the hydropyridines are used to treat hypertension and angina, which is amlodipine, because amlodipine is a dihydropyridine calcium channel blocker together with felodipine. So it is good to prescribe this medication in this patient because it is good in managing hypertension and angina. Next.
So we have the amlodipine and atorvastatin. So amlodipine and atorvastatin is a combination of a calcium channel blocker and a HMG-CoA reductase inhibitor or the statin. Amlodipine is used alone or together with other medicine to treat angina or the chest pain or high blood pressure. High blood pressure adds to the workload of the heart and arteries. Chronic use of amlodipine can cause, if it continues for a long time, the heart and arteries may not function properly. This can damage the blood vessels of the brain, heart, and kidneys, resulting in a stroke, heart failure, or kidney failure. And we have the atorvastatin is used together with a proper diet to lower cholesterol and triglyceride or the fats level in the blood. This medicine may help prevent medical problems such as chest pain, heart attack, or stroke that are caused by fats clogging and blood vessels. And it may also be used to prevent certain types of heart and blood vessel problems in patients with risk factor for heart problems.
So our recommended medication in this patient as he shows some symptoms of heart failure is that given that ivermectin is well-known rising star among cardiac drugs due to its mechanism of action, we recommend the patient to use it to treat congestive heart failure by preventing the hypolarization that activates the S8 nodes of sodium channel that it can lower heart rate. So why ivabradine? Because ivabradine used to treat certain adults with heart failure to decrease the risk that their condition will worsen and need to be treated in a hospital. It is also used to treat a certain type of heart failure in children at 6 months of age and older due to cardiomyopathy. And also, this drug is under a class of hyperpolarization activated cyclic nucleotide gated channel blockers, and it can slow heart rate so that heart can pump more blood through the body each time it's beats.
So we have the recommended medication for the dyspnea. So what are the causes of dyspnea? Respiratory causes may include asthma, acute exacerbation of, or chronic congestive obstructive pulmonary disorder, pneumonia, pulmonary embolism, lung malignancy, pneumothorax, or aspiration. And we recommended for the patient to use oxygen in managing the symptoms of dyspnea. It is appropriate to give oxygen to hypoxic patient with dyspnea. However, caution should be used in patient with COPD as you can suppress the respiratory drive in chronic carbon dioxide retainers, and therefore giving oxygen with a goal saturation of 90% is an appropriate first step.
So here are some of the drug interaction of ivabradine. So using this medicine with any of the following medicines is not recommended. Your doctor may decide not to treat you with this medicine or change some of other medicines you take, such as conivaptan, fluconazole, clarithromycin, and so on. Here are some of the samples.
So we have the side effects of ivabradine. The more common is the blurred vision, chest pain or discomfort, fast or irregular heartbeat, headache, lightheadedness, dizziness or fainting, nervousness, pounding in the ears, slow or irregular heartbeat, unusual tiredness. And we also have the incidents not known, confusion, dizziness, faintness, and so on and so forth. And we have less common, the seeing flashes of light.
So the drug interaction and side effects of oxygen. Oxygen is kind of risk of using in therapy because oxygen is generally safe, but it can cause side effects because they include dry or bloody nose, tiredness, and morning headaches. And oxygen poses a fire risk, so you should never smoke or use flammable materials when using oxygen.
So we have the dosing regimen of ivabradine is to lower the risk of worsening heart failure. We recommend the patient to take 5 milligrams of ivabradine orally twice daily after meals. Ivabradine should be administered to the patient for 2 weeks in order to track their heart rate until it reaches 50 to 60 beats per minute. The dose will be increased up to 7.5 milligram to control the symptoms of tachycardia if the patient heart rate is higher than that which is considered normal. If the patient is experiencing bradycardia, they should reduce their daily dose of ivabradine by 2.5 milligram from the recommended dose of 7.5 milligram. Therapy should be stopped when the patient is taking a dose of 2.5 milligram of the medicine.
And the dosing regimen for the oxygen is that uh, oxygen is just for managing the shortness of breath. So it doesn't, the patient will use as he needed to relieve his shortness of breath. And then here's our the plan. We suggest if the patient is experiencing overweight, taking steps or moderate exercise may help to reduce orthopnea. Second is to relieve symptoms temporarily by sleeping in a more elevated position. And third is monitoring the elevated jugular venous pressure to prevent in becoming an heart failure. And lastly, monitor the patient blood pressure and oxygen saturation.
So lastly, we have the healthy lifestyle to prevent heart failure. The first one is the quitting smoking. Second, having enough sleep, eating a heart healthy diet, being physically active, tracking your daily fluid intake, keeping track of symptoms, tracking cholesterol intake, and monitoring your blood pressure. And that's all. Thank you for listening.